Thank you, everybody, for coming this evening to hear me talk, and hopefully we can all share some knowledge. Is that all right? Yes. Yeah. Okay, right. So the synopsis for this evening's webinar, I will touch on three main areas: epidemiology, the diagnosis, and of course, looking closer at the impact of endometriosis on fertility and beyond. In terms of epidemiology, which is the part A of my talk this evening, I want to ask five key questions: the what, the how much, the when, the where, and the among whom. Now, it is important that we learn and understand epidemiology because, of course, it defines the disease, but also it helps us target therapy and also better individualize treatment. Now, in terms of definition of endometriosis, or the what, we all know it's a chronic neuroinflammatory condition associated with a range of debilitating acute and chronic health conditions. And that would include pain, infertility, characterized, of course, by ectopic endometrial glands and stroma outside the uterus. It is a surgical diagnosis with histology. The pathophysiology, unfortunately, is still, a matter of intense research. We know of many theories that have been proposed, right from the original Sampson's theory on retrograde menstruation to the very more current discussion around how perhaps social evolution and mismatch in terms of repetitive ovulation and menstruation might have resulted in endometriosis. So in order to classify or stage the disease better, many have come out with classification systems, but unfortunately, there are still no universal consensus. In terms of ASRM classification, you can see there it is probably one of the most widely used, and I myself use it often. However, there are plenty of limitations, as you can see there with the classification system. But more importantly, of course, also it does not correlate well with prognosis, in particular fertility. And then we have the NZN system, where it's much more focused on the deep infiltrating disease and classification of that, but again, quite poor correlation with prognosis and symptoms. The EFI system, of course, focus very much on the infertility patients, but it really is more around natural pregnancy after surgery, and of course, doesn't correlate very much with pain at all. In terms of the how much, you see here in the busy table, where there are mainly retrospective studies that are out there on, sample sizes ranging from just under 60 to over 2,000. And, oh, thank you. and you can see that the prevalence varies very widely from 2.5% to 55% when we're talking about endometriosis in women with infertility. Now, what about infertility in women with endometriosis? Equally, you can see that the prevalence or the odds ratio is increased from 2 to 4 times, depending on the study we're looking at. In terms of the when, we can see from studies that have been done that endometriosis is very much a disease in women in the reproductive age. And you can see the peak there of, in the mid-20s and thereabouts, with lower incidences either side. In terms of amongst whom, when, who does it occur? It's interesting to note that the risk factors extends all the way from in utero, early life factors to adulthood. As you can see there, associated with prematurity, lower birth weight, and some of these with the question marks, it's just conflicting studies, some showing no effect, some showing increase or decrease effect. And when you look at childhood and adolescence, equally early menarche associated low BMI, physical activity, smoke exposure. And in adulthood, menstrual length, as you can see here, low BMI, alcohol, caffeine use, but this decrease with higher parity, cigarette smoking, regular physical activity. But there's really not a lot of data around specific diets, nutritional impact. So there's more a need for more research in that. So when we look at these, one can't help but think about the critical appraisal in terms of why we see so much heterogeneity and variation in the epidemiology data for endometriosis. And it's very much down to selection bias, study design issues. Many of these studies are retrospective, observational, so suffer from the impact of bias, and many of them are reliant on statistical significance and not a measure of association or precision. There's a lack of characterization of the exposure very often, and of course the temporality. And the lack of adjustment of these confounders very often results in very varied prevalence of the disease. So, as we said earlier, a clear understanding of the epidemiology is important because it helps us derive better management strategies. Because of the flaws, we are rather restricted, and so we are really in need of much better way of screening our population, gathering bigger data, using much more precise modern epidemiological methods, like directed acrylic graphs to define the associations, and of course using robust guidelines to guide us on epidemiological studies. Coming to the diagnosis of endometriosis, that's part B of my talk. And I would like to talk about the current diagnostic pathways, challenges, of course, the different non-invasive technologies to image endometriosis, and of course, the minor issue of biomarkers. We all know that the symptomatology of endometriosis is very varied. I mean, in clinic, you see patients coming with sometimes with pain, sometimes without pain, infertility, with or without pain. They can have absolutely no symptoms or some menstrual irregularities, abnormal uterine bleeding. So it is quite a hard thing to do clinically to pinpoint who has endometriosis and who's not, and hence most likely contribute to the high incidence or the big problem of a delay in diagnosis. We highly rely on surgery and histology diagnosis because that's the only way to diagnose endometriosis. And so early diagnosis is really quite fundamental in terms of decreasing the morbidity, earlier treatment, potentially reducing progression of the disease, and earlier advice on fertility options. So the question here is, can imaging replace surgery? What if it can? It would be so much easier and better for all of us, including our patients, of course. So in order to evaluate another test, whether we want to replace it or whether we want to use it as a triage test, there are ways to assess these diagnostic accuracy of these tests. And one of the ways or methods that's been described with the Cochrane group, as you can see in the reference there, is the use of snout, rule out tests, or rule in spin tests in terms of assessing the particular specific test, whether it's able to replace or triage the disease. And here we take the diagnostic performance of the index test. For a replacement test, you really want it to be very sensitive and very specific, so you're accurate in your diagnosis. And for a triage test, you'd want it to be fairly sensitive and reasonably specific. So let me explain a little bit about the triage test in terms of snout. So SN out, OUT, a little mnemonic to remember. So if you have a high sensitivity and you have a negative test, then you can quite confidently rule out endometriosis, which means actually the diagnostic surgery becomes unnecessary, and you can reduce the number of interventions surgically. But the positive test, of course, then does not exclude the condition, and you might need further testing or evaluation. Now, a triage test with a high specificity, or SPIN, S-P-I-N, so spinning in, positive tests that would suggest a likely endometriosis diagnosis, which means you can proceed then to discuss medical or surgical intervention with the patient. And in some cases, you may want to delay surgical treatment for individuals, for example, fertility patients, where they would not want to go and have surgery, but at least you know the possible diagnosis there. A negative test, of course, is not conclusive. And then, of course, you proceed to your surgery or alternative triage tests if they exist. So if you look at the table here, I have tabulated the results of the meta-analysis for endometrioma and also deep infiltrating disease. And if you use on the left-hand column, you can see the snout test and the spin test. You see what each of these modalities, whether it's ultrasound or MRI, and how accurate they can get to diagnose the condition, whether you're talking about triaging or whether you're talking about replacement. Now, the interpretation of that result there that I'm showing you is basically this, that for endometrioma, ultrasound or MR are usually likely right, because you can see that with the snout and the spin, as well as the replacement sensitivity specificity, they're really quite approaching or qualify for. However, if you're talking about deep infiltrating disease, then ultrasound's likely right if it was positive for deep infiltrating disease. But MR, of course, is much better, and they are likely right if they're positive or negative for deep disease. And this finding has further been confirmed by two more, much more recent studies, both showing, as we've discussed, fairly high sensitivity and specificities for the condition of endometrioma and deep infiltrating disease. What about AI? Everybody's talking about AI nowadays. It can't get away from anywhere from discussing AI and machine learning. Now, I am by no means asking you to read this table in detail, but all I want to point out is that there are already studies, and certainly much more recent studies, that have used machine learning, artificial intelligence technology to classify images obtained from radiological, usually ultrasound, MR modalities. And they have fairly reasonable sensitivity and specificity. But they are retrospective. And in my opinion, with all these machine learning and AI studies, we really ought to put them to clinical trials testing. Because as we've learned from other areas in assisted conception with embryo imaging, so on, putting these technology through to clinical trials may tell a slightly different story. So we need to await the results of trials to tell us a little bit better whether that is possible to use AI. I'm sure it's coming, but we'll need to wait for more robust data. In terms of biomarkers, there have been quite a number of systematic reviews that have been published in this area, and I've selected the Cochrane review here because it's really comprehensive, just under 150 studies and just over 15,000 participants including 122 biomarkers. As you can see here, no surprise, the prevalence of endometriosis is very variable. And the markers that have been looked at varies from growth factors, apoptosis factors, to microRNAs and so on. If we use the same assessment of replacement or triage testing for this particular area, you'd see that none of these currently have the adequate cutoff for a triage or replacement test. Similarly, for biomarkers of urinary origin, is similar. There's insufficient evidence to recommend it for testing, for replacement or triage testing. Endometrial marker, again, numerous markers have been proposed and has been trialed in many clinical studies. And again, very disappointingly, most of them are not, apart from PGP 9.5. Now, PGP 9.5 is a neuro pain marker, and it's interesting that the authors of the Cochrane review had issued caution in terms of using it as a replacement test, even though some studies have shown reasonable qualifying sensitivity and specificity reading. And certainly my group in Southampton has done this many years back, and we really didn't find any difference in PGP 9.5 in endometriosis or non-endometriosis patients. So the current recommendation, strong recommendation from ESHA, still remains that we are not in a position to use biomarkers to diagnose endometriosis at the moment. Now, eventually, I'm sure biomarker testing will combine with all the other non-invasive testings and clinical characteristics to bring us non-invasive testing, earlier diagnosis for our patients. But at the moment, laparoscopy remains as the gold standard for this purpose. And there is a fairly, written out sort of pathway for biomarker testing and development from preclinical discovery to commercialization. It is a process, and it requires investment in terms of time, finance, and patience. And it is important that the commercialization is ethical and based on robust data. Although increasingly we're seeing that the commercialization is done through different means, and we're seeing some of these products in the markets, and that's another day's talk. So in summary, what do we do in terms of diagnosis? Well, imaging is definitely the way forward currently. and ultrasound, 3D ultrasound, of course, nowadays most of us use, and organized MR if the clinical scenario requires, to give us better understanding, particularly if you're planning surgery, there's deep disease, to proceed with planning of surgery or not with patient. So last but not least, the impact of endometriosis on fertility and beyond. So in this part of the talk, I'd like to address how endometriosis influences natural conception and IVF prognosis, and then try to answer the question, would treatment help? The natural fecundity of patients with endometriosis and without endometriosis, as you can see there, is, of course, decreased, and that's based on data published by several papers. And of course, it's common sense not to use any medical treatment for the treatment of endometriosis, treatment of endometriosis patients with fertility problems, because you will give them contraception, which of course is not desired. In terms of this particular Cochrane review, which looked at medical treatment as adjunct in terms of natural conception, you see that it actually shows, interestingly, surgery plus medical treatment probably increases pregnancy rate compared to either surgery or placebo. Now, just hold that thought there, because when you look at the actual studies that have been included in that particular review, they actually included studies that are you have natural conception and ART. So it's not just on natural conception, and therefore the view from the ASHA group is still, of course, not to prescribe post-operative, preoperative hormone suppression for patients who are desiring pregnancy. And when you look at laparoscopic surgery versus diagnostic laparoscopy, the studies all point towards, of course, common sense tells us that if we treat the disease, it has a better success rate in terms of intrauterine pregnancy confirmed by ultrasound. But it's important to note that in these studies, they're quite old studies now, with no severe endometriosis patients in that group. So a lot of the data is based on this particular study, weighting, and you can see that those with laparoscopic surgery, there's a higher success in terms of pregnancy, but over the period of 36 months. So you have to have time to await that better success rate in patients who had surgery. So we can summarize that actually surgery helps, but you need time for pregnancy to occur. In terms of endometrioma, unfortunately, no RCTs in this area. So the only thing we can do is look at some of the data from systematic review. And you can see the pregnancy rate of about 30% to maybe slightly over 40% with surgery plus ART or surgery alone. In terms of deep disease, again, no RCT data, but reported single center data or with no controls shows a 20 to 50% success rate in terms of spontaneous pregnancy, no bowel or with bowel involvement. So the recommendation currently in terms of natural conception, operative laparoscopy could be offered, and that's what we're doing, I hope. And it may be considered in patients with endometrioma, and also, of course, operating for deep disease is really reserved more for an option in symptomatic patients. So what about IVF? I mean, those of you who are involved with IVF, currently there's no RCT comparing IVF versus no intervention. It probably never happened. So we'll give that a miss. We can use retrospective data to observational data to meta-analyze, and this is this study we published a number of years ago now, and compared to no endometriosis, ART have a similar, as you can see there, overall, there's a similar live birth rate, decrease cumulative pregnancy rate, but a lower number of mean oocytes retrieved. But when we looked at the subgroup analysis, you've no difference in the milder groups, but in a more severe ASRM classification, there is a lower live birth rate. But of course, it's retrospective data and it's subgroup analysis, data from subgroup analysis. So the key question here is, therefore, can IVF compensate this problem related to subfertility in patients with endometriosis? Now, this is more an extrapolation because we know that IVF may not always compensate for endometriosis-related infertility. Because if you look at the egg yield with normal reserve and you have a reasonable egg yield, your cumulative live birth will, of course, be good. But if your ovarian reserve is lower, which many patients with endometriosis may suffer from, whether they have surgery or not, then the live birth rate would inherently be lower. And as I said, with the data we showed more severe, the likelihood of birth rate is lower with more severe disease. So the take-home message, I think, really is that IVF can maximize the cycle fecundity because you're able to create more embryos with eggs if the reserve is reasonable at the earlier stage, potentially. And of course, the possibility of offering fertility preservation in these patients. So the next question is, should we then recommend surgery before IVF? Well, before we even contemplate surgery, we need to understand that surgery can result in some damage to the ovary. And this is direct damage, so to the primordial follicle pool because of energy, trauma, injury, or indirect damage to the primordial follicles because of the same surgical insult. Now, as far as the comparison of impact surgery prior to IVF is concerned, there really aren't that many studies because they're probably very difficult to perform a study of that comparison. So there's one study in the literature so far which shows in a mild disease, you have a higher live birth rate for those who have treatment compared to no treatment. So we have to rely on some indirect evidence by comparing surgery versus no in patients with no endometriosis. And for the live birth there, in that comparison, there's no difference. So with the ASHA recommendation, clinicians are not recommended to routinely perform surgery prior to IVF to improve live birth rates. And for more severe disease, we will, of course, always be guided by patient symptoms. In terms of endometrioma, again, the systematic review we've done a few years back now showed no difference with no disease. But interestingly, in the subgroup analysis, in treated endometrioma group versus no treatment, the basal FSH is higher, lower number of oocytes retrieved, and certainly a higher cancellation rate. And that is the experience we have in clinical practice as well. So in terms of endometrioma, from a guidance point of view, clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rate, as the current evidence shows no benefit and surgery is likely to have a negative impact. But of course, in the case of endometrioma, you might want to consider depending on symptoms and, of course, accessibility of follicles. So this is a pictorial demonstration of how surgical impact may be is a double-edged sword. It may help, but we have to be mindful when we're operating of the possible damage to the ovarian tissue and the ovarian reserve. So how to proceed with IVF treatment planning for women with endometriosis, then, you would say? Well, in order to think about a plan for IVF for our patients, certain pre-treatment considerations. This is age. Well, how old is the patient now? What's their current ovarian reserve? Because we know that age is associated with higher age is associated with higher risk of miscarriage due to poorer quality of eggs, due to higher incidence of aneuploidy. Accessibility of the ovaries. Do they have a huge endometrioma on one side, on both sides? Symptoms and surgical indications, and of course the patient, because we always have to listen to our patients. So the principles of ovarian stimulation, just a brief revision. As we know, in a monthly menstrual cycle, there's cyclical recruitment of about 10 follicles. Of course, this depends on ovarian reserve for individual women, develops in waves within one menstrual cycle, right? And this creates what we call the FSH window. So follicular growth leads to an increase in various factors, including inhibiting estrogen. Negative feedback, therefore, results in the dropping of FSH and the closing of the follicular recruitment window, so that you get a follicular ovulation cycle. In ovarian hyperstimulation cycle, you have an extended FSH window. So because we are using exogenous FSH to stimulate the ovary, so the window is left open for a longer duration of time, right? So you get this multifollicular development, and hence you can collect many more eggs in an IVF cycle, right? So the question then in IVF, a lot of people, well, nowadays we use agonist or antagonist protocols, and this is a cartoon illustration of agonist protocol, which has a short and a long agonist. Some people start GnRH agonists, such as daclopeptyl, triptyralin, earlier in the previous cycle, and then some people use the flare protocol, where they start the GnRH agonist to suppress the ovarian function in the cycle itself. And then it shows you the HCG trigger timing, and then the oocyte vitrification or embryo vitrification timing. And this second figure shows you the GnRH antagonist protocol, where the antagonist is used rather than the agonist, which also acts to suppress ovarian function, so that the IVF FSH application with gonadotrophins takes over and provide the egg follicular development. And so this is just to show you, for those of you who are not familiar with IVF, what we do. So is downregulation with GnRH agonists a better ovarian stimulation protocol? Because for a very long time, a lot of us use downregulation for patients with endometriosis, and proviso that actually switches off the hormones, stimulate endometriosis growth. But actually, the clinical data was, based on a very, very small study that was published in the Cochrane a number of years back. And the newer study now casts a significant doubt on the use of long protocol downregulation to enhance IVF outcome in patients with endometriosis. You can see here in the Hector Georgiou's data, published a Cochrane database, you have a very low quality of evidence and very uncertain in terms of how it impacts on the prognosis of patients with endometriosis. and very low certainty of evidence, it's depicted here. It's really any effect, meaning it's no better than tossing of a coin. So the actual recommendation is that extended disadministration of GnRH agonists prior to IVF treatment is not recommended, as it does not provide any improve any the live birth rate of women with endometriosis. As far as agonists and antagonists is concerned, which is better? No two protocols have shown any difference, and therefore it's up to your whole unit's preference which one you want to use. In the general population, what can you use? My preference and certainly recommendation here is, of course, antagonist protocol, because using the antagonist protocol, you have the option of GnRH agonist trigger, and therefore it's much safer in terms of lowering the incidence of ovarian hyperstimulation syndrome. And certainly in high responders, there's no question the GnRH antagonist protocol is the recommended one. Here, due to, of course, enhanced safety, decreased risk of OHSS. And in the normal responder, of course, again, antagonist has come up as a winner due to the safety profile of being able to use the GnRH agonist trigger. Now, in low responders, there is no specific advantage in using one or the other. The risk of low responder hyperstimulating is extremely low, and therefore, it's not necessary to worry about the use of agonists or not for ovarian trigger to reduce their OHSS risk. Now, this is an interesting development in Europe. It's getting more and more, prevalent, popular, and it is the progestin pram of ovarian stimulation protocol, which perhaps is more used in Asian countries, China, but certainly it's much of a trend now in Europe. And it involves only women who are coming for ovarian preservation, fertility preservation, because, of course, using a progestin during treatment to suppress ovulation means that you cannot transfer fresh embryos. But it's a very cost-saving strategy. As you can see there, medroxyprogesterone in the UK for 30 tablets is £1 each tablet, which is very cheap compared to any other suppression strategies that we have. In terms of dosage, due to time, I would show, this is based on evidence, of course, but I would say from the data that I can see, the optimal dosage would be anything between 150 to 300. Because we've got to remember that higher dose is not equivalent to better eggs, it's not equivalent to better prognosis. Yeah, and individualization with ovarian reserve testing nowadays is much more used due to the higher safety profile. And these algorithms tells you what dose to give to the particular patient. It's important that whilst we're discussing all the clinical treatment, not to forget that endometriosis is a multifaceted disease. It impacts on various different ways in a woman, right from follicular genesis, data, and embryo development, albeit that there are conflicting data, but certainly data there suggesting possibilities of the impact. Of course, around uterine receptivity, perhaps in a much lesser impact manner. But not to forget that, its influence on placentation and fetal development and growth and all the impact there, such as preterm birth and so on. And of course, in the end, the well-being of the offspring. More recent data from us highlights that potentially this is much more, in terms of the primate group compared to multiparous patients. So With that, I shall provide you with a summary for the part C, the last part of my talk, where I hope I've illustrated to you that stages and subtypes of endometriosis impacts on reproductive outcomes differently, and that the pre-treatment agonist downregulation treatment is no longer recognized to confer any benefit to live birth. Antagonist and agonist triggers are both suitable for treatment with endometriosis, but of course, the progestin prime ovarian stimulation protocol may be used more cost effectively. And in terms of dosing, 150 to 300, no need to go way above that. And the ovarian reserve testing algorithms potentially would help with a reduction in OHSS risk. So with that, ladies and gentlemen, I hope you enjoyed the talk. Thank you very much.